Good afternoon and good morning, everyone. Thank you so much for joining us for our webinar today. My name is Travis Atkinson. I am a board member with the Crisis Residential Association, and I am pleased to be hosting and moderating today's panel discussion. Um, Give me just a moment and we will get our slides ready for um, the day. Our webinar is called Chairs or Beds, Crisis Residential, Crisis Stabilization, and the Somewhere to Go Conundrum. If you are just joining us, feel free to type your name and where you're from or where you work into the chat. And I will introduce our panelists in just a few minutes. But just some quick housekeeping items. First of all, CRA is a 501c3 nonprofit organization dedicated to supporting the operational and clinical functions of crisis residential programs around the world. You can learn more about the organization at crisisresidentialassociation.org. A few housekeeping items. Please feel free to use the Q&A feature as well as the chat for any communication with us. I will be monitoring that in the background. If you have questions for the presenters, the panelists, we will be starting off with some questions, and then we will be opening up the floor at the end. And then a recording will be made available to those who have registered, and it'll be made first available to members and then to everyone else about a week after that. And lastly, there is a survey that you'll receive at the end of our webinar, which we would love your feedback on what you liked and what you'd like to see more of. So a couple details about the crisis by the numbers. There has been a severe decline in psychiatric hospital beds nationwide, both inpatient as well as state psychiatric hospital beds. Um, the American Psychiatric Association reports an 89% decline in psychiatric beds, and the wait times within emergency departments are substantial, 34 hours sometimes for a person awaiting bed in a psychiatric hospital. And so these challenges or this dearth of resources puts a lot of strain on our system. It puts families and individuals in crisis in even more stressful situations. And fortunately, we have seen a crisis continuum evolve since the 1970s that has um, existed to address some of those challenges. But there is a conundrum, and that is in the somewhere to go area. And the conundrum is about understanding what services um, do within that and asking questions like, are they interchangeable? Are crisis stabilization and crisis residential, are they different tools that are solving different problems, or where is the overlap? And then does one promise outcomes that the other can't, related to safety, to sustainability, to recovery? And that are both necessary to function optimally, or can a community, quote, get by with just one? One of the reasons why this question persists or exists is that the initial SAMHSA guidelines named these three core elements, someone to contact, someone to respond, and a place to go. And crisis residential services were not initially named in that list of essential services. It was listed as kind of an afterthought. Now, in the 2025 guidelines, it's a much more robust description of all these different crisis services, and crisis residential and peer respite and some of those other longer term stays are included in some of those definitions in that communication. But there was a critical time of expansion of crisis services that happened between ARPA funds and now with rural health transformation around what's being invested in. And so in an ideal crisis continuum, we look at it as a series of services intended to divert people from higher levels of care. So instead of calling 911, a person could call 988 or a crisis hotline. Instead of having the police show up, you could have mobile crisis teams or co-responder teams. The area we're going to talk about today is right in the middle here. These two services, 23-hour observation and crisis residential, places that either people can walk into or people can be referred to in order to get that timely care in a facility versus in their home or over the phone. Some quick overviews of the model definitions, and these are based on SAMHSA's Behavioral Health Emergency Crisis and Crisis Related Services Guidelines, which were published last year. So when we talk about crisis stabilization in the context of today's webinar, we mean a chair, a short-term facility-based emergency behavioral health care. It could be linked to a hospital or freestanding, and it focuses on rapid assessment, medication management, and stabilization so people avoid unnecessarily hospitalization or ED boarding. So traditionally, these have been known to be facilities that keep people for less than 24 hours, and that was because of old historical residential rules about what would change in billing after you hit hour 24. But some of those have been relaxed or modified so that people can stay longer, sometimes 3 days, sometimes maybe even up to 5 days. The setting is chairs or recliners, often in an open milieu, or you could have private rooms in some cases, but they're typically no wrong door, serving people at all acuity levels and accepting both voluntary and involuntary admissions. The prescriber team, excuse me, the care team is made up of prescribers, nurses, clinicians, technicians, and oftentimes peer supports as well. And then the core services are medication initiation, withdrawal management, triage, assessment, things like that. Now, these can go by many other names, like crisis observation units, walk-in crisis centers, psychiatric emergency services. Unfortunately, each state does it a little bit differently. And then crisis residential services are conceptualized more in a bed uh, uh, heuristic. So it's a non-hospital, home-like residential program providing 24/7 monitoring and support over several days to 2 weeks, aimed at stabilization, skill building, and connecting people to ongoing care. So the duration there is more like 1 to 2 weeks. The setting, as I mentioned, is in a home-like environment, not a locked hospital unit. It's primarily serving people who are voluntary. Some states allow involuntary admissions, but for the most part, it's a voluntary program. The treatment team looks similar to a hospital or to the crisis stabilization team that we mentioned. Whoops, I apologize. And then the core services include individual and group therapy, a therapeutic milieu, discharge planning, resource connection, focusing on some of those elements of recovery. Now, what can be confusing is that the names of these services differ again across state lines, and some, like in Ohio, they refer to a crisis residential program as a crisis stabilization unit, when in fact, crisis stabilization, as we're talking about it today, is just a little bit different. So sometimes we have to do some code switching or some interpreting in that area. But you could consider a treatment timeline to look something like this. In the first 24 to 72 hours, you can take care of some of those medication concerns on safety planning and risk assessment. But then the longer you stay in a program, the more you can do. And your shorter programs that only do stabilization, they might be putting the pressure of those other two boxes on the outpatient system. And so that's something that we want to talk about today with our panelists as well. Now, there are research articles behind both types of services, and what they really show, especially in the crisis residential space, is that they can reduce cost, they can keep high client satisfaction, and they can keep comparable clinical outcomes to what they're being compared to, which in most cases is the psychiatric hospital. Now, crisis stabilization centers have been able to show significant cost savings in things like diversion from um, emergency departments or jail, as well as reduced use of law enforcement. So with that, I would like to introduce our panelists for today. The first is Heather Honaker. Heather is the president of the Crisis Residential Association. The second is Paul Galdys with Recovery Innovations. And the third is Kaylee Finch with the Zepf Center. Heather, Paul, Kaylee, thank you so much for being here today. And I'd like to just start off with a question for one of you. I'd like to actually start with Heather. Heather, what would you say is the goal of crisis residential and crisis stabilization as you understand it?
Sure. So the goal of crisis residential really is to provide a safe, home-like environment to an individual experiencing a behavioral health crisis that is in their community and is easy to access. When I think about crisis residential services and just like the things that make them a little bit different than crisis stabilization. I think of the three E's, at least that's what I've come up with. One is empathy, and that's from a multidisciplinary team. So crisis residential programs have clinicians, they have peers, sometimes nursing staff, sometimes not, access to a prescriber, really a whole team within the house that wraps their arms around the individual to help them through their crisis. The next is environment. Crisis residential programs in general exist in houses, much like the one you or I live in. One of my favorite things to brag about the crisis residential program I used to work in was if I were to take you on a tour and I didn't tell you what we did, you would think that you were at a bed and breakfast, not a mental health facility. That's exactly what we want to see in crisis residential services and what makes them so special. And the third E is enough time. So, really, a service that gives someone enough time to stabilize, but also to mobilize any supports that they need for recovery beyond that initial stabilization. And I'm actually going to kick it to Paul to talk about the goal of crisis stabilization.
Happy to. Thank you so much, Heather. A lot of great points were actually made by Travis earlier. It's confusing when you think of the language and what we're actually using. So when we're talking about these kind of under 24-hour sort of options, and if I refer to crisis stabilization solely as that to start, it's about getting immediate access to care, how the person, when and where the person needs it. In any scenario. And I think the things that have driven this over the years, and to be honest, would have driven a lot of my work, have been the idea that unfortunately, when we don't have a place where anyone can go, meaning accept everyone, regardless of acuity, challenges, or other things, they get involved in the criminal justice system. And, if we look at conservative numbers, it's 1.2 million people in the United States, meaning 24,000 in an average state, are incarcerated that have challenges largely driven by mental health and substance use challenges. So when there's a resource that says yes every time you see diversion. And I think that's really important that we're connecting. When you talk about environment, Heather, the last environment we want to see them in is locked in a prison cell or in a jail cell.
Absolutely.
Um, so some of the purposes, we stop that. We start giving an alternative. And those of us that know crisis intervention team or CIT with law enforcement, they want an alternative. They seek it around the nation, but they often don't have it. And so the other thing they do, which was in one of Travis's first slides, was they take them to hospital emergency departments that are ill-equipped to do this very work. And we saw in his slide, it was data I hadn't seen. 34 hours is the average length of time someone's waiting in a hospital emergency department. And any of us that have any sort of issue that has taken us to a hospital emergency department, I start losing patients within 2 hours. 34 hours in a place that doesn't offer a bed, doesn't have a window, can't see fresh air. These are challenges that are just completely unacceptable. And so we have to do better. So really the design is to get to immediate access. And look, really fair points that often the environment's not, it's not going to be the quality that we'd like to see in a crisis residential. And at the same time, you can create environments that are supported for the individual. It's a place where we would want to go, where our family members, if we're in acute distress. And so it's all part of that. And the other thing I'll note is I like your three E's, Heather. Empathy matters a lot. Our approach in all of our facilities is peer first and peer last. And we're driven with the understanding that this under 24 hours, uh, that's there by licensure requirements. It allows you to say yes every time. Because if you picture any of you out there that run facilities and you have 16 beds, when number 17 shows up, no matter how much you want to accept them, you can't. You're full. A chair version lets you do that, but a chair version doesn't let you stay more than 24 hours. And to be honest, shouldn't. You shouldn't be sitting in a chair for more than a day. You should have a bed. You should have private space. You should have a window. You should have opportunities for those sort of things. And that's actually, when we lean into this later, why all of our programs actually are connected to programs that have extended stay beds as well, because that is not the right environment for longer lengths of stay.
Thank you, Paul. Kaylee, I want to bring this question over to you because at Zepf Center, you operate both of these services, Zepf
Mhm.
Center in Toledo, Ohio. Tell us about how you conceptualize the difference, whether it's who goes to which one or what order that they go in.
Yes. So 23 hour, it's a very unique thing that we offer here at the Zepf Center. So I have the privilege to kind of be the gatekeeper of the agency. So my specific department is emergency services. We're the access point for the entire agency. So whether that's inpatient level or outpatient level, right? So somebody comes to the front door, right? We're the access point. We do the assessment, which helps us determine the level of care that somebody needs. But it's also a mutual opportunity, right? The opportunity for us to see what they need, but also for the individual being served to express what they need. Um, and maybe they don't know what they need, and that's okay. And that's where maybe 23-hour observation would come into play. And although, yes, it may be seen as a chair or a bed kind of route that we're at a crossroads of what way to go, but it's an opportunity for somebody to kind of go into that least restrictive environment and not only buy us time to kind of see what will be a better fit, but allow that individual to have a safe place to go where they feel supported, where they have access to people and professionals, as well as us kind of having that opportunity to start that stabilization process because we know that it's not a linear process, it's a very fluid process that's ongoing. So we
Mhm.
definitely utilize this service more often than not when we're working with individuals.
Great. Thank you, Kaylee. Um, I want to actually stick with you, Kaylee, to start off this next question, which is what is
Mhm.
lost when a community doesn't have one of these services? Or how would you notice if tomorrow your crisis residential program or crisis stabilization program went away?
Yes. So it's actually an interesting question because I had came from a previous crisis contract holder from my previous employer, and there was a gap in time where when Zepf was awarded the contract, we didn't have a crisis residential unit for several months. And, seeing what that gap in the community looked like, there were higher recidivism rates. There were higher utilizations of law enforcement or misutilizations of it. And so I think I was a witness to seeing what would happen when the community didn't have it. Although we still had the emergency services umbrella, which was my specific department, and we could provide that, outpatient level of care or get them to a hospital. But even still, we knew that they might not have met that level of care. And so, on one hand, it may have been seen as a misutilization, but it was our only option to utilize the service. So I think not only access is lost in the community when we don't have the service, but also connection is lost because what happened was a lot of the individuals that we were serving they found out that the previous contract holder was shut down through word of mouth or by physically going to the building and it was just empty. And so being a place where a lot of people would consider us to be their primary and only support, and just like that, it was gone. It was catastrophic. It was detrimental. It was also right after the peak of COVID that all of this was happening. So there was just a lot of things happening, a lot of factors involved. And I think we noticed it in the community in the areas that I identified, but also just speaking to the bigger gap in the community that, it caused because people didn't have an option.
Yeah, so you've lived that out. Thank you so much, Kaylee.
Definitely.
Heather, same question to you. I imagine as president, you get to hear a lot of encouraging stories of crisis residential providers, but also times when the service is under threat or communities decide to
Mhm.
close those services. So either hypothetically or experientially, what do you believe is lost when a
Yeah.
community doesn't have these services?
I think Paul touched on this a bit earlier. Just our law enforcement officers are spending a lot more time with individuals in crisis. Individuals are going to the emergency department. They're spending time in inpatient hospital settings and unfortunately in jail when these services don't exist. And in addition to that, if either of these services, stabilization or residential, doesn't exist in your community, families also lose access to another option before a person's crisis reaches its worst point. So then we don't have the support we need, and maybe we have a loved one who we can see is not doing well, or they've said they've needed help, but they're not bad enough or in a place to be admitted to a hospital, then families are left trying to figure out what to do or how to help the individual. And so I think that's what I've seen just on a personal experience level of having living in a community where a crisis service did temporarily shut down, is then people are left going, wait a minute. what do I do now? Do I have to wait until I need to be in a hospital, but I don't want to go to a hospital? And so we really see an impact all across a community and a system in a way that's really that strains it and that's really unhelpful when we don't have these services.
Thank you, Heather. Paul, same question.
You know, these are two different questions in some ways, Travis. So if you think of what's lost, in my past, I've worked in management for managed care. I've had assistant director positions in state government in a couple of different roles. And if you think of what's lost, oops, you changed it on me. You're trying to test my memory, aren't you? If you think of what's lost in a community, I think what's lost is getting someone connected to the care that best aligns with their needs is what's lost. Them being in the least restrictive environment is what's lost in some ways. So I think when comes to connecting and you think of those worlds of structuring systems, if you don't have that, if you don't have it, what you're going to see is that people will have to round up. It is possible that they get squeezed out and simply get into the community sooner than they're really ready. They aren't getting support they need. And we all know it's very challenging to wrap around outpatient services for individuals in most of our communities. The resources just aren't there to effectively do it. So you can round up and they can stay inpatient for an extra week. It's a secure setting. Unfortunately, transitioning, preparing for discharge, re-engaging with the community, tackling all of those issues that really contributed to the crisis are going to minimally happen because you're not able to get back in the community in the same way. I think what you notice when you don't tackle those things is probably people stay in higher levels of care, more restricted settings longer. And what I would see is more likely that they're pushed out before they're quite ready to get back to where they were. And therefore, we're going to see higher rates of reutilization of the crisis system, criminal justice system involvement, law enforcement responding, all of those resources, I think are what you notice. But again, for the person, it means they're probably in a more restrictive setting than they need to because that's the only option available.
Hmm. And I wonder if the picture of that loss actually looks similar to the picture of the absence where people have never even brought these services into the community in the first place. Uh,
What was
I've
your data
seen,
chart, Travis? I'm sorry to ask that again, but the reduction in hospital beds, that's what was filled up, state hospital beds where you stayed for weeks, months, or even years.
yep.
And sometimes not a great loss at all because they weren't the right thing, but that's what existed.
Hmm. And so I've seen pockets of the country that are controlled by certain health systems that don't have an interest in bringing alternatives in. And so then the emergency departments and the psych hospitals and probably the jails are carrying a lot of that, never even knowing how much better things could be for their community, just kind of taking things at the status quo. So thank you. Um, Heather, what would you say are some of the limitations of crisis residential services? What can't they do or what are they not designed to do?
So, crisis residential services are not intended to be the front door or a program that serves any and everyone who is experiencing a crisis at any level of acuity. So, that is a big difference. I do think they can handle a higher acuity than most people assume. And in some communities, experience a low utilization because of that myth. Um, but in general, it's folks who are voluntary to seeking treatment who are in need of a service for a couple of days and beyond, and those who um, would benefit from the structure of that program. And so, for someone who really just needs a couple of hours, needs to get restarted on their medications, or maybe just needs a space to cool off for a bit, I wouldn't say that a crisis residential program would be the best fit. Then I would say, of course, 23-hour having that space. And same goes for perhaps someone who just doesn't know what their next step is. So that's the biggest limitation of crisis residential. Uh, Community-wise or across the country, a limitation is just if communities don't have them. And sometimes communities are hesitant to bring them in if they don't understand that they can accept a pretty high acuity. And there's a really heavy reliance on good staff training and understanding mental health crises and being able to support individuals to be able to divert from hospitalization. So
Uh,
yeah, if you
Can I
need
can
a
I
little more
press you on that a little
direction,
bit? When
sure.
you say they can accept a higher level of acuity than people think, Does
Yeah,
that mean that sometimes they'll accept people that psych hospitals won't accept people, or what do you
absolutely.
mean?
Yes,
Why? Why would they do that?
absolutely. One of my favorite things that a local hospital used to decline an admission for was someone who, was maybe suicidal or had pretty high needs, but they also needed a CPAP machine at night. My hospital said, absolutely not, that is unsafe. And we would say, of course you can come here. So it's times like that. And in the community that I live in, the local psychiatric hospital admission criteria and the crisis residential program criteria are identical. And so, really, sometimes it comes down to someone's comfort level with having an individual come to a crisis residential program. There's a lot of education that goes into this when you operate these programs, to going to your local hospitals and your community partners and saying, hey, here's what our admission criteria is. Let's talk about what that looks like in real life and how we could support someone. But yes, to answer your question, Travis, absolutely. Crisis residential programs pretty regularly accept folks that a hospital would say no to.
Okay. Sometimes individuals with a personality disorder, like narcissistic personality disorder,
Mhm.
will be part of an ACT team, or they will
Mhm.
have a treatment plan that says, in fact, they're not supposed to go to the hospital because they find it to be counterproductive. Would that
Mhm.
also then be an instance where a person might go to a crisis residential program intentionally, even though they could meet the criteria for inpatient?
Well, sure, it could. And I think that that would be more on an individualized level, right? If like the issue is that the person um, maybe then we'll have the same experience with the crisis residential program. And hi, Steve. Thanks for joining us. And then maybe become dependent on that, or it somehow becomes not helpful for their treatment. I would say that's a bigger conversation across that person's treatment team. But yes, absolutely. If a hospital has said, hey, for whatever reason, this person can no longer come here, of course, a crisis residential program would be willing to consider bringing that person on.
Yeah, we have Steve Fields in the as a guest today, an attendee. I consider Steve to be one of the godfathers of crisis residential services, but I remember him telling a story where he said when they first opened up, they had to take every referral from San Francisco General that was an overflow that would have otherwise gone to the psych hospital. And so it reminds me that crisis providers finding ways to say yes constantly. And and so he might have turned some doctors on their head by thinking, oh,
Yeah.
there's no way I could ever refer this person somewhere. So, Kaylee,
Absolutely. I want to add one more thing to that is
sure.
we had a slogan where we said focus on what's strong, not on what's wrong. Sometimes if you look at these
Ooh,
pre-admission screenings and they're just like drenched in reasons why a person shouldn't come to a facility or why they're not safe, it's really challenging the team to go, okay, well, what could they get out of coming here? How can we help them? And not just immediately saying no.
okay. Kaylee, what are the limitations of your two programs?
So, starting off with CSU, I would say
Which
with
means
it,
in Ohio,
oh, Crisis Stabilization Unit. Yes, good catch.
okay,
Which would be
which
crisis
is
residential. So I'll
thank you.
focus on the
Okay.
actual staying, the
The,
bed,
the
not the
the
chair.
confusion
Yes.
in vivo. Thank you.
Yes, perfect example of it, right? I was testing you all. Yes, so the bed's not the chair, right? So I think with it being a voluntary unit, I see both sides of that. I think people um, hear that and they think, oh, I can come and go, right? And no, that's not the case, right? On the other hand, it is a locked unit. So although it is voluntary, the doors are still locked. And I think sometimes when individuals get up there thinking that it's completely fully voluntary, that definitely has been a misconception. But then again, we are very thorough in our informed consent process and the intake portion of it, where we're very informative on what to expect, what that looks like. Um, and so, with all of that said, with it being voluntary and going back to what I said in the beginning of kind of this conversation about our goal being least restrictive environments, I would agree with what you said, Heather. We have serviced individuals that are stepping down from the state psychiatric hospital here. And some people might find that very alarming, being as we are a low level of care. We're a hands-off facility. We don't have emergency meds. We don't have a pharmacy in-house, right? Those being some limitations as well. But also focusing on what we can control and your beautiful quote that you gave, right? And how we can say yes versus, well, here's where the areas of concern lie, and here's why we can't service this person. But, trying to navigate through that and meeting them where they're at. Um, so.
Great. Thank you, Kaylee. Paul, what limitations would you say there are with crisis stabilization centers?
So if I use that language for that 23-hour receiving center function, there shouldn't be any limitation in who you bring in. Of course, once you bring them in, you do your assessment work. There are individuals, it tends to be about 4% that have medically complex challenges that can't be addressed. Because remember, there's no sort of medical screening ahead of time. There's none of those sort of things that happen. You bring everybody in.
Hmm.
Uh, no matter what, first responder drop offs, walk in, whatever the case. And about 4% of those end up going to hospital emergency departments for complex medical issues, many of which are returned and come back once those are addressed. But that's a challenge there. So I don't know that there are true. Well, the other limitation pretty clearly is those units, as they're built, are under 24 hours. Very few acute crises are typically fully resolved in under 24 hours. You have to connect to the right levels of care next. Again, I mentioned that we typically have bed units. In fact, all of our facilities, I believe, now have bed units attached to those sort of programs so we can get them connected when they're complex and they need our resources. Some go to crisis residential. Of course, some go to the community with ongoing support. And there are some that even go to inpatient care. So the limitation in part is it's under 24 hours for those chairs, which it should be. It's not an environment meant for long-term um, placement, and then you have to get the supports to them and the right ones. So your other limitation is often what's available in the community. It leans into your second thing, right? Crisis residential might take people with high acuity. Challenges if they already have 16 in a 16 bed one, they're not going to be available. So do we have capacity in our community to connect that person to the right care becomes the real one of the big challenges. So when it comes to discharge planning, engagement with empathy, finding the natural supports, that has to happen immediately. You're on a pretty tight timeline.
Here, Kaylee, any response?
I would agree with that. I think 23-hour is short-term stabilization, if stabilization even happens. And also, how do you define stabilization, right? It could just be being in a supportive environment for an hour while they get to watch TV or listen to music, and then maybe their needs have been met by that, and we do a crisis plan or some kind of safety plan, and then they're on their way, back to the shelter. So it just depends. But yeah, I would fully agree with that. It's short term. It also shouldn't be any reason that I can think of besides, the rare 4% circumstances of a no. The 23-hour we can meet the needs of an individual. People come in with different needs, right? A crisis is a very subjective experience. It looks different across the board for one versus another. So, yeah, I would
Hmm.
100% agree with that. And we see it every day, every night.
Okay.
Can I just say one other thing there, Travis, which is
Yeah.
sometimes people think of these 23-hour stabilization or receiving centers as replacements for residential. I think you just heard they're not. They're not designed to do the same thing. They're
Mm.
designed to take the emergency department out of this mix. They're designed to create a path where when law enforcement has engaged with someone, which unfortunately they're still our primary first responders for individuals in crisis, is to say, bring them here for help, bring them for care, and we have to figure this out. When you think of flow, if you got a 2 week average length of stay in a crisis residential with 16 beds, you can serve 32 people in the month. That's just what capacity is. Whereas if you have 16 chairs, you can have a new person in each day. You can serve 480 people in that month and get them
Yeah.
connected to the right services. So there's real benefits, but the limitations in this question are very real. You are not going to do what a residential does. You're not going to be able to engage them for 2 weeks. You can't provide those supports.
Yeah.
Your structure doesn't allow it.
And I guess I just wonder on the other side of that, Paul, you're talking about statistics and volume and being able to
Yeah.
see more people. That might presume then that the issues that those people have are, immediate access to medications, getting plugged into certain resources. there's a therapeutic element
Yeah.
to being in a group with other people and spending a week together. I've even heard instances of some of the early crisis residential programs, and this still exists in some places, like just outside of Baltimore, where people work 24-hour shifts. So they are up for 16 hours and they get paid to sleep because being a part of that rhythm, you want to call it
Yeah.
circadian or otherwise, makes you feel more connected. Heather, I'm curious your thoughts about that, just the impact of
Mm.
milieu and moving from, incorporating the intentional connection over a period of time with people and what impact that has in the crisis treatment experience.
Yeah, and I want to start by saying, Paul, I agree with you. I think communities who have strong, robust crisis continuums would have both. Like that would be ideal if there was a place for folks to go who can, step in for a couple of hours, get what they need to be stabilized, and then also have an option to go and stay for longer. The One of my favorite parts about working in a crisis residential program was always mealtime. There was no like staff versus guests. We called individuals receiving care guests, eating areas. You all eat together at one table. And just the value of that time to connect and how everyone's guard is down and you're just there being people. I wasn't therapist or director or any other person at that table. I was Heather sitting next to Joe and Sarah having lunch. And so that's part of what you're talking about, Travis, is just having that space where everyone is together and feels safe. There's some accountability there when you're sharing that environment with other people. Um, and it was also really great to see how guests would support one another. Folks who had been there for a few days, really wrapping their arms around someone who just walked in for the first time, to helping them feel settled and tell them what to expect. And so there's a big part of crisis residential treatment is that milieu experience and the environment that I mentioned earlier.
All I would add, though, is that should be true everywhere, and I'll
Yeah.
acknowledge it's not. Environments don't all look like that. We have our oldest of facilities doesn't really have a setting where we do that. And we have others where if you find your way in Baton Rouge, Louisiana, and at our crisis center, it is the best food around, and you sit right next to people at the table and hang
Yeah.
out and do those things. We work on puzzles together, and there's plenty of things you can do even in these shorter term environments. It's how they're built sometimes, and hopefully purpose built so that you can do those very things.
Yes.
I will acknowledge though there are many that aren't like that.
Mhm.
All right. I want to move us on to our next question. And um, the question is, how do your crisis services balance being widely inclusive but not coercive? I'll start with you on this one.
Well, it's a tricky question, Travis. The truth is, I think we all know the nature of care, voluntary or even involuntary, since we do accept everyone. So typically in our programs, you are also serving people involuntary. We know that engagement is key. So our program, the last I looked, which has been a couple of years since I looked at the data, I believe we're the second largest employer of peers in the nation after the United States Veterans Administration. And peer first, peer last mattered. Engagement, finding a way for someone to drive their treatment course is really important. Even when involuntary, you know that success comes from someone engaging in services that make sense to them, creating a path that aligns with their goals. So that's always it. I always think sometimes you think of these assessments happening and we're going to align your services. And typically the first few questions include, what can we do for you? What does better look like for you? What does support look like? What are the things that make sense? And trying to drive that. I do want to be fair and say there are coercive behavior. There's involuntary. There's intramuscular injections that could happen with antipsychotics when someone's under involuntary care, but those are remarkably rare compared to the typical experience of individuals. So setting up your environments matter a lot. Creating separate space for someone when they need it matters a lot. And I know we are all constrained by budgets, but I think you design things so that care is still driven by the person. And we're fortunate enough to have so many peers bringing their lived experience that inform everything we do, that they'll tell us when this doesn't feel right, this isn't the structure that works. And we've adapted and changed through the years.
Paul, what would you say to the passionate mental health rights advocate who thinks that putting everyone through a locked door so that you can serve anyone could
Yeah.
have could harm people?
Yeah, it could. I suppose that's true. And you do your best work. I think we heard Kaylee mention the same way. The door is locked in many of these programs, still often for their own safety, protection, confidentiality, and other reasons programs could be. And for most individuals that we're serving, they can leave when they want to. They have those options still. You have to make sure they know that. Ideally, many of our programs now have outdoor space so they get comfortable. If you need a quieter area, you have a separate place built for that. There are rooms, even though these are chair based programs. And you're right, this observation idea is it's often open, Travis. And there's also rooms for those that need it. You have to create environments that are going to work and balance those things if you're going to be optimally successful. Um, Man, it's something we've always struggled with, though. I know we've heard others say, well, you can't have peers engaging with individuals in involuntary sort of forms of care. And we have heard that through the years. And our peers have said, look, they want to make a difference. They want to engage and support. They've been there themselves. They've been brought in the back of a police car to a facility. And unfortunately, when it happened years ago, they were brought to a facility called jail. They were brought to emergency departments and handcuffed to gurneys. These are things that aren't happening there. Our levels of seclusion and restraint are far lower than inpatient units. And we've already heard inpatient units don't take everybody. They filter them out and send them to Heather because they're not going to do it. That one's too difficult. We do. And we still don't have to seclude and restrain. I think what we've also learned in all of our programs, if you go to any of our facilities, and I've overseen operations in 10 states through the years, there's no plexiglass there. There's nothing between those we serve and the care that's happening from our team. Well, we know that engagement's what matters. I think plexiglass sends the wrong message that it's not safe. We don't
Mhm.
trust you. Of course we do. And if our goal is to get someone connected as quickly back to their community, we better be side by side with them. And so, there are things you can do to mitigate this, Travis. But yeah, you can't fully avoid it either, right? What I would say is everything. Our previous CEO, he really pushed hard to say we're not doing seclusion and restraint. And I remember I was sitting with a law enforcement official many over a decade ago when we had this conversation. Is we're not going to do seclusion and restraint. And I'm like, well, the regulations require it. You have to have a seclusion room just in case you need it. Yeah, but I'm not giving anybody the key, right? They're not doing it. I believe this shouldn't happen. The problem was the program would turn people away that had been violent before, were under the influence of methamphetamines or other challenges because there was a high risk of harm, and we don't offer that option. And of course, the harm that came to those people that were turned away is they went to emergency departments and were handcuffed to gurneys. They did go to jail. And
Mhm.
I think this is a path to stop it. And it's not perfect. It's part of why you have to design flow, Travis. You have to have an option to get people to the right level of care as quickly as possible. But when you can, with just 16 chairs, help roughly 500 people get connected to care instead of a criminal justice system or an emergency department, I think it's something every community should have access to.
Hmm. Yeah, and something that's probably worth the part two of this panel discussion, whenever that were to happen, would be to talk even more about the populations that we're most trying to help. That like what exactly are those symptoms? But you bring up an important point, Paul, and that is right now, if inpatient psychiatric hospitals are receiving all of the referrals and they don't have a volume issue, then they can be discretionary about who they let in their door and who they don't. And they get to make up the rules. And many of us who have worked in assessment spaces trying to get people into hospitals, we've seen this happen. But if crisis stabilization and crisis residential services are working very well, then the side effect is that hospitals are going to have to accept more people. They're going to have to get rid
Right.
of their blacklists and have and take all levels of acuity because that's what they'll need to do to make money. So, Heather, I want to bring this question over to you.
Mhm.
How does crisis residential balance being widely inclusive but not coercive?
I think sometimes we forget that safety and autonomy can coexist, that we don't need to remove people's autonomy for them to be safe. And when I think about coercion or times that we coerce people into treatment, we're doing it and we sometimes we feel good about doing it because we say we're doing it to keep you safe. But we don't have to do it that way. We can think about this in a way that's much more human and person centered. and have voluntary options that accept high acuity. You mentioned a blacklist, and I can think of a time where I had a screener call me and say, "Hey, so and so wants to come back, but I just wanted to check with you because she tried to punch you last time. Like, I know that was," I said, "Well, I hope she doesn't try again this time, but like, let's see." There was no like, oh gosh, no, she can never come here again. And I know some places, hospitals will do that if there's a history of violence or, it's really about honoring people, honoring their recovery, understanding that people change and not basing someone's admission on any one experience. But I think that's part of it, Travis. And thinking about designing your programs, are we designing them with locked doors, especially crisis residential programs, because we have to? Does it make us feel better? What happened if we had secured programs with delayed egress that still keeps you in there, but you can get out if you want to? And then what happens if we just leave the door unlocked? I can't tell you how many times I would have folks, I would tell them, I'll open the door and you can leave whenever you're ready to. And they would still choose to jump the fence. So some of it too is just making sure that we're talking to people and letting them know that they have choice and fully informing them when they're in a service. And then Paul, you mentioned peers. That's a huge, huge part of this, having peers available, accessible, able to walk alongside someone, let them know what to expect and help them figure out what's next. I think that's a big part of balancing this.
I'm smiling because I'm imagining this client coming back to the crisis residential program and putting up a banner that said like the rematch or something, like since they tried to punch the first time.
Oh,
Yeah,
yeah.
not appropriate, but still funny.
No, I
Uh,
have had folks jump over the fence and come back over the fence and say, "Sorry, Miss Heather, I actually want to stay." I'm like, "I'm impressed you got over the fence twice. Like, come on
that,
in."
that's
Yeah.
an interesting intake approach. Yeah. Again, the front door works.
Mhm.
Um, Kaylee, same question to you. How about your services? Both.
Yes, so I won't be too redundant, but I do want to emphasize the fact that, being the gatekeeper, like the first impression starts right at that door, right? As soon as we walk out and grab the individual from the lobby, that we're already starting that timer of, are we working to build your trust, but also are we working to show you that we value your opinion, your safety, your rights, ethics, whatever it might be? We're starting that at that moment. And I think with all of that said, that's an ongoing process as well. So although we are inclusive, it's a very informed process, very transparent. We're meeting them where they're at. We recently, as in the past couple of years, have switched to kind of a firehouse model, right? We go to the client. And I think surface level speaking, yes, it's a process, but deeper level, it shows them that we're meeting them where they're at and kind of these subliminal messages that we are sending the individual indirectly, right? So I kind of will leave it at that because I don't want to be too redundant, but yes, I do want to emphasize the fact that autonomy and safety are the end goal.
Great, thank you. The next question is, what are the costs of the services that you represent compared to more intensive options like emergency department, jail, psych inpatient, some of which people could be accessing more than one of those in the same 24 hours, and so could be quite a bill to compare to. Heather, we'll start with you. What are some of the ballpark numbers of the
Mhm.
costs of crisis residential?
Yeah, so crisis residential services, you shared some research at the start of this. They have one of the stronger evidence bases across the crisis continuum, and that's in part because they've been around for a really long time. And there have been several studies that have compared crisis residential outcomes and costs to inpatient hospitalization. And one study that, I go back to all of the time says that crisis residential programs cost about 44% less per episode than inpatient psychiatric hospitalization, and they have similar, better outcomes. And so 44% is a huge difference and something that I really think we need to pay attention to, especially as we're thinking about how much this costs the community, how much more it would cost for someone to stay in a hospital, how much longer someone has to stay in a hospital when these alternatives don't exist, right? And so there's just really a huge financial burden there when these programs don't exist.
Thank you. Paul, same question.
Uh, I'm going to draw on my background and say it depends, Travis. No matter how much we like to do research, and we can show, as Heather said, that it's cheaper per episode, and those of you that know, when I developed the crisis resource need calculator in 2017, okay, it cuts your costs in half, even at the very least. So I think all of those are true, but it depends who the payer is, and that's our challenge. To me, as a group, we should be uniting to make sure these are all recognized as healthcare services, and everyone pays for them. So if everyone doesn't pay for them, and let's say your crisis residential or these stabilization services are fully paid by state general funds, well, then it's cheaper for them to go to the hospital because, to be honest, state general funds don't have to pay for all of that. What does it cost my Department of Health if someone goes to jail? I just saved a bunch of money because they don't cost anything. It goes in a different budget, and so I think one of the in some ways this is a good calling. We can show the cost benefit, but what we have to do is get different divisions of state government together in a room to show it lowers your state expenses and you enforce parity and make sure insurers all pay for these very vital services, which they would if you look at the analogies on the physical health side. And if we do that, it not only saves money, but it's a good case. And even when we do these for crisis care and we go to commercial insurers and say it's cheaper than your alternatives of inpatient and emergency departments, and they say, you know what's even cheaper? They don't say this out loud, having the state pay for it instead, which is what happens now.
Again, it's all these incentives at play that people don't realize, right? And like this happens in Ohio where the health plans pay for the inpatient stay, but not for the crisis services. So what's everyone incentivized to do? Not build more crisis services if the health system's going to take it over. I want to go to a question that came in for the Q&A. We're got less than 10 minutes here. It says, how do you handle individuals who may not meet criteria for a level of care due to their defined crisis being housing related, but not really experiencing increase in mental health symptoms, excuse me. Kaylee, send that your way first.
Yes, so that is, believe it or not, something that we deal with quite often at the Zepf Center. One of our famous lines is, although we're not a shelter, we're gonna try and help meet some level of your needs, right? And maybe that is utilizing 23-hour, or maybe that is staying on CSU, our residential unit with beds, for a few days just to kind of bridge that gap. But we are very transparent up front that, we can't get you an apartment overnight, right? And I go back to the limitations part of the panel that we talked about because that could be a limitation. Because a lot of people come in with these preconceived ideas of like, oh, I'm going to get a house, I'm going to get this, I'm going to get that. And with it being a very short-term stabilization unit, there also comes reality, right? But at the end of the day, if we could help bridge the gap and get them a case manager or whatever it might be, a list of resources, we're still helping them in some capacity. But yes, we do run into that a lot. And I think a lot of our staff feel like a broken record almost of, we're not a shelter, but here's what we can offer you. But yes, it's definitely a very real thing that we face daily.
Heather, Paul, anything you'd like to add?
Yeah, I would say, we tried really hard not to let that be our reason to say no. Like to really stop and think about how else can, to Kaylee's point, how else can this person be supported? Um, I had someone that I worked with who would sort through the referrals and hand them to me and say, "Well, he's just homeless." And I'd say, "Well, think about it for a minute. If you were homeless right now, might it be helpful for you to be in a safe and supportive environment for a little bit? Might it be helpful for you to talk through what's going on and to get connected to other supports? Like, are there still ways that we can help without just turning this person away?" And so, really, just not looking at every referral or piece of paper that comes across your desk for admission as like just a piece of paper. Like that's a person with needs. How can we support them? And it's possible that there are some folks who kind of come through multiple times with that same scenario. And then it's how can we connect with our case management team or our outreach team to figure out how to meet this person's needs. If it's not us, who else can? Crisis residential services, what I've heard across the country in these programs are that they want to help. Whether they're the right service or not, whether you call and what you describe is outside of what they can do, like if you're admitted to the program, they still want to help you figure out what's next or who to get connected to. So don't let that be your one and only reason to say no. Really think about the person and how to serve them.
It's one of our benefits as those SAMHSA defined high intensity behavioral health emergency centers, the 23 hours. You take everyone, just like an emergency department. You don't know what they're there for, but everyone gets served, evaluated, and gets care. Getting someone into a bed requires authorization and other challenges from health plans often, and so that criteria is probably not there if you, as it was described. But our role is to get someone to the best possible place. So I think sometimes we think of crisis centers as, man, a fantastic resource to get things started, but you're only good as your community in many ways. If you can't connect them to the right services, supports, you're going to struggle. And they'll be back tomorrow or they'll be back next week. And we hope they keep at least coming back instead of the criminal justice system or struggling on the streets. But these are the sort of scenarios I think all of us as crisis providers, probably everyone on this call, they fought to advocate for we need this resource in our community. We keep getting stuck here, and we're probably never going to stop doing that. But I think that's an essential function of a crisis provider.
Yeah, great. Um, I want to give each of you probably like 1 minute in closing to say anything that you haven't been able to say yet, or anything else you'd like to share with our audience today. And I will start with Kaylee.
So first and foremost, I just want to say thank you so much for the opportunity. I love collaborating and also having a platform to just connect with everybody and have these important conversations because our community is bigger than just our local community, right? We're all doing the same thing. We all have the same goals, but they might look different depending on where you're at and what you're working with. But at the end of the day, we're a people serving business, and that's the field that we're in. So I just want to say I appreciate everybody and happy to connect.
Great. Paul?
I'd encourage you to never stop advocating. Keep fighting for what you believe in. We have to advance these systems. We are not there yet. I think Heather, I think you're in Virginia, and I was meeting with a rural Virginia community, and their challenge is this: they don't want to put someone in jail when they're going through a mental health challenge, but if they take them to the hospital emergency department, they have to sit with them until they get connected to a bed. And on average, they said
Yeah,
they sit with them for 72 hours, 3 days. Shift change happens in
a
the hospital,
long
one
time.
on one in a room without windows or a TV. These are not okay. And these are things that have to change if we're going to get to the services and resources we believe people deserve when they're in crisis.
Yeah. Heather, final word?
For those of you who operate crisis services or involved in your communities, kind of a combo of what Kaylee and Paul said, like reach out, collaborate, and don't stop. If you are frustrated, if you feel like your community doesn't have what it needs, find examples of communities that do. Pull in research about cost savings of programs like Crisis Residential. Use those as tools to advocate. The services that any of us have operated or that we work alongside with or have advocated for didn't happen overnight and without the intervention of people who care very deeply about bringing crisis services and access to them to their communities. So there's been so much good work done across the country, and there's still a lot to do. So keep hanging in there
Yeah.
with us.
Yeah. Great. Heather, Kaylee, Paul, thank you so much for being on our panel today. We greatly appreciate it. We hope everyone enjoys the rest of Crisis Residential Week. You can follow CRA on LinkedIn